spinal muscular atrophy, also called autosomal recessive proximal spinal muscular atrophy in order to distinguish it from other conditions with similar name, is a rare neuromuscular disorder characterized by loss of motor neurons and progressive muscle wasting, often leading to early death. The disorder is caused by a genetic defect in the SMN1 gene, which encodes SMN, a protein widely expressed in all eukaryotic cells and necessary for survival of motor neurons. Lower levels of the protein results in loss of function of neuronal cells in the anterior horn of the spinal cord and subsequent system-wide muscle wasting. Spinal muscular atrophy manifests in various degrees of severity, which all have in common progressive muscle wasting and mobility impairment. Proximal muscles and lung muscles are affected first. Other body systems may be affected as well, particularly in early-onset forms of the disorder. SMA is the most common genetic cause of infant death. Spinal muscular atrophy is an inherited disorder and is passed on in an autosomal recessive manner. As of 2016, no drugs for SMA have been approved, even as a number of therapeutics remain in late-stage clinical trials. Classification: SMA manifests over a wide range of severity, affecting infants through adults. The disease spectrum is variously divided into 3 to 5 types, in accordance either with the age of onset of symptoms or with the highest attained milestone of motor development. The most commonly used classification is as follows. The most severe form of SMA type 1 is sometimes termed SMA type 0 and is diagnosed in babies that are born so weak that they can survive only a few weeks even with intensive respiratory support. SMA type 0 should not be confused with SMARD1, which may have very similar symptoms and course but has a different genetic cause than SMA. Motor development in SMA patients is usually assessed using validated functional scales CHOP-INTEND in SMA1 and either the Motor Function Measure Scale or one of a few variants of Hammersmith Functional Motor Scale in SMA types 2 and 3. The eponymous label Wernicke-Hoffmann disease refers to the earliest clinical descriptions of childhood SMA by Johann Hoffmann and Guido Wernicke. The eponymous term Kugelberg-Welander disease is after Eric K.L.'s Hendrik Kugelberg and Lisa Welander, who distinguished SMA from muscular dystrophy. Rarely used Dubowitz disease is named after Victor Dubowitz, an English neurologist who authored several studies on the intermediate SMA phenotype. Signs and symptoms. The symptoms vary greatly depending on the SMA type involved, the stage of the disease, and individual factors. They commonly include causes. Spinal muscular atrophy is linked to a genetic mutation in the SMN1 gene. Human chromosome 5 contains 2 nearly identical genes at location 5q13, a telomeric copy SMN1 and a centromeric copy SMN2. In healthy individuals, the SMN1 gene codes the survival of motor neuron protein which, as its name says, plays a crucial role in survival of motor neurons. The SMN2 gene, on the other hand, due to a variation in a single nucleotide, undergoes alternative splicing at the junction of intron 6 to exon 8, with only 10 to 20% of SMN2 transcripts coding a fully functional survival of motor neuron protein and 80 to 90% of transcripts resulting in a truncated protein compound which is rapidly degraded in the cell. In individuals affected by SMA, the SMN1 gene is mutated in such a way that it is unable to correctly code the SMN protein, due to either a deletion occurring at exon 7 or 2 other point mutations. All patients, however, retain at least one copy of the SMN2 gene which still codes small amounts of SMN protein, around 10 to 20% of the normal level, allowing some neurons to survive. In the long run, however, reduced availability of the SMN protein results in gradual death of motor neuron cells in the anterior horn of spinal cord and the brain. Muscles that depend on these motor neurons for neural input now have decreased innervation, and therefore have decreased input from the central nervous system. Denervated skeletal muscle is more difficult for the body to control. Decreased impulse transmission through the motor neurons leads to decreased contractile activity of the denervated muscle. Consequently, denervated muscles undergo progressive atrophy. Muscles of lower extremities are usually affected first, followed by muscles of upper extremities, spine and neck, and, in more severe cases, pulmonary and mastication muscles. Proximal muscles are always affected earlier and to a greater degree than distal. The severity of SMA symptoms is broadly related to how well the remaining SMN2 genes can make up for the loss of function of SMN1. This is partly related to the number of SMN2 gene copies present on the chromosome. Whilst healthy individuals carry 2 SMN2 gene copies, patients with SMA can have anything between 1 and 4 of them. With the greater the number of SMN2 copies, the milder the disease severity. Thus, most SMA type 1 babies have 1 or 2 SMN2 copies. SMA 2 and 3 patients usually have at least 3 SMN2 copies, and SMA-IV patients normally have at least 4 of them. However, the correlation between symptom severity and SMN2 copy number is not absolute, and there seem to exist other factors affecting the disease phenotype. Spinal muscular atrophy is inherited in an autosomal recessive pattern, which means that the defective gene is located on an autosome. 2 copies of the defective gene, one from each parent, are required to inherit the disorder. The parents may be carriers and not personally affected. SMA seems to appear de novo in around 2 to 4% of cases. Spinal muscular atrophy affects individuals of all ethnic groups. Unlike other well-known autosomal recessive disorders, such as sickle cell disease and cystic fibrosis, which have significant differences in occurrence rate among ethnic groups, the overall prevalence of SMA of all types and across all ethnic groups is in the range of 1 per 10,000 individuals. The gene frequency is around 1 to 100, therefore, approximately 1 in 50 persons are carriers. There are no known health consequences of being a carrier. A person may learn carrier status only if one's child is affected by SMA or by having the SMN1 gene sequenced. Affected siblings usually have a very similar form of SMA. However, occurrences of different SMA types among siblings do exist. While rare, these cases might be due to additional de novo deletions of the SMN gene, not involving the NAIP gene, or the differences in SMN2 copy numbers. Diagnosis. Very severe SMA can be sometimes evident before birth, reduction in fetal movement in the final months of pregnancy. Otherwise, SMA1 manifests within the first few weeks or months of life when abnormally low muscle tone is observed in the infant. For all SMA types, patient will present hypertonia associated with absent reflexes. Electromyogram will show fibrillation and muscle denervation. Serum creatine kinase may be normal or increased. While the above symptoms point towards SMA, the diagnosis can only be confirmed with absolute certainty through genetic testing for biallelic deletion of exon 7 of the SMN1. Genetic test is usually carried out using a blood sample, and MLPA is one of more frequently used techniques as it also allows establishing the number of SMN2 gene copies. Pre-implantation testing. Pre-implantation genetic diagnosis can be used to detect SMA-affected fetuses, especially when undergoing in vitro fertilization. Prenatal testing. Prenatal testing towards SMA is possible through chorionic villus sampling, cell-free fetal DNA analysis and other methods. Carrier testing. Those at risk of being carriers of SMN1 deletion and thus at risk of having offspring affected by SMA, can undergo carrier analysis using blood or saliva sample. Routine screening. Routine prenatal and neonatal screening for SMA is controversial, because of the cost and because of the severity of the disease as well as lack of approved treatment. Some researchers have concluded that population screening for SMA is not cost-effective, at a cost of $5 million per case averted in the United States. Others conclude that SMA meets the criteria for screening programs and relevant testing should be offered to all couples. Management. There is no pharmacological treatment to spinal muscular atrophy. Care is symptomatic. Main areas of concern are as follows. Orthopedics. Weak spine muscles may lead to development of kyphosis, scoliosis and other orthopedic problems. Spine fusion is sometimes performed in SMA2 patients once they reach the age of 8 to 10 to relieve the pressure of a deformed spine on the lungs. Patients with SMA might also benefit greatly from various forms of physiotherapy and occupational therapy. Mobility support. Orthotic devices can be used to support the body and to aid walking. For example, orthotics such as AFOs are used to stabilize the foot and to aid gait. TLSOs are used to stabilize the torso. Assistive technologies may help in managing movement and daily activity and greatly increase the quality of life. Respiratory care. Respiratory system requires utmost attention in SMA as once weakened it never fully recovers. Weakened pulmonary muscles in SMA type 1-2 patients can make breathing more difficult and pose a risk of hypoxiation, especially in sleep when muscles are more relaxed. Impaired cough reflex poses a constant risk of respiratory infection and pneumonia. Non-invasive ventilation is frequently used and tracheostomy may be sometimes performed in more severe cases. Both methods of ventilation prolong survival in a comparable degree. Although tracheostomy prevents speech development, nutrition difficulties in jaw opening, chewing and swallowing food might put patients with SMA at risk of malnutrition. A feeding tube gastrostomy can be necessary in SMA type 1 and more severe type 2 patients. Additionally, metabolic abnormalities resulting from SMA impair beta-oxidation of fatty acids in muscles and can lead to organic acidemia and consequent muscle damage, especially when fasting. It is suggested that patients with SMA, especially those with more severe forms of the disease, reduce intake of fat and avoid prolonged fasting. Cardiology. Although the heart is not a matter of routine concern, a link between SMA and certain heart conditions has been suggested. Mental health. SMA children do not differ from the general population in the behavior. Their cognitive development can be slightly faster, and certain aspects of their intelligence are above the average. Despite the disability, SMA-affected people report high degree of satisfaction from life. Palliative care in SMA has been standardized in the Consensus Statement for Standard of Care in Spinal Muscular Atrophy, which has been recommended for standard adoption worldwide. Prognosis. Generally, patients tend to deteriorate over time, but prognosis varies with the SMA type and disease progress, which shows a great degree of individual variability. The majority of children diagnosed with SMA type 0 and 1 do not reach the age of 4, recurrent respiratory problems being the primary cause of death. With proper care, milder SMA type 1 cases live into adulthood. forward. Long-term survival in SMA1 is not sufficiently evidenced. However, recent advances in respiratory support seem to have brought down mortality. In SMA type 2, the course of the disease is stable or slowly progressing and life expectancy is reduced compared to the healthy population. Death before the age of 20 is frequent, although many patients live to become parents and grandparents. SMA type 3 has normal and near-normal life expectancy if standards of care are followed. Adult-onset SMA usually means only mobility impairment and does not affect life expectancy. In all SMA types, physiotherapy has been shown to delay the progress of disease. Research directions. Since the underlying genetic mechanism of SMA was described in 1990, several therapeutic approaches have been proposed and investigated which primarily focused on increasing the availability of SMN protein to motor neurons. The main research directions are as follows: SMN1 gene replacement. Gene therapy in SMA aims at restoring the SMN1 gene function through inserting specially crafted nucleotide sequence into the cell nucleus using a viral vector, scAAV9 and scAAV10 of the primary viral vectors under investigation. Only one program has reached the clinical stage, AVXS101, a proprietary biologic under development by Avexis which uses the scAAV9 viral vector to deliver the SMN1 transgene. As of June 2016, it remained in Phase 1 clinical trial, with published results showing marked improvement in treated infants compared to the natural course of the disorder. Work on developing gene therapy for SMA is also conducted at the Institute of Myology in Paris and at Genzyme Corporation. SMN2 alternative splicing modulation. This approach aims at modifying the alternative splicing of the SMN2 gene so that to force it to code for higher percentage of full-length SMN protein. Sometimes it is also called gene conversion, because it attempts to convert the SMN2 gene functionally into SMN1 GA. The following splicing modulators have reached clinical stage development. Nusinersen is a proprietary antisense oligonucleotide developed by Ionise Pharmaceuticals and Biogen, which is administered directly to the central nervous system using an intrathecal injection once every few months. In July 2016, one of two Phase 3 trials of the drug was ended early with encouraging results, with Biogen deciding to file for regulatory approval for nusinersen in type 1 SMA. As of August 2016, a Phase 3 trial in types 2 and 3 SMA patients was ongoing. RG7800 and RG7916 are proprietary small molecule drugs administered orally developed by PTC Therapeutics and Hoffmann-La Roche. As of June 2016, the clinical development of RG7800 has been put on hold due to animal toxicity, while RG7916 is advancing to Phase 2 trials across all patient ages and SMA types. LMAO70 is a proprietary small molecule drug administered orally, being developed by Novartis. As of June 2016, the drug remains in Phase 1-2 trials in infants with SMA type 1. Of discontinued clinical stage molecules, RG3039, also known as quinazoline 495, was a proprietary quinazoline derivative developed by Repligen and licensed to Pfizer in March 2014, which was discontinued shortly after, having only completed Phase 1 trials. PTK-SMA1 was a proprietary small molecule splicing modulator of the tetracyclines group developed by Paratech Pharmaceutical and about to enter clinical development in 2010, which however never happened. Basic research has also identified other compounds which modify SMN2 splicing in vitro, like sodium orthovinodate and aclarubicin. More phenotype antisense oligonucleotides remain in preclinical studies at the University College London. SMN2 gene activation. This approach aims at increasing expression of the SMN2 gene, thus increasing the amount of full-length SMN protein available. Oral salbutamol, a popular asthma medicine, showed therapeutic potential in SMA both in vitro and in 3 small-scale clinical trials involving patients with SMA types 2 and 3. Besides offering respiratory benefits, a few compounds initially showed promise but turned out ineffective upon more extensive research. Butyrates held some promise in vitro studies, but a clinical trial in symptomatic patients did not confirm their efficacy. Another clinical trial in pre-symptomatic types 1 to 2 infants was completed in 2015, but no results have been published. Valproic acid was widely used in SMA on experimental basis in the 1990s and 2000s because in vitro research suggested its moderate effectiveness. However, it had no efficacy in achievable concentrations when subjected to a large clinical trial. Some research suggests it may actually aggravate SMA symptoms. Hydroxycarbamide was shown effective in mouse models and subsequently commercially researched by Novo Nordisk, Denmark, but demonstrated no effect on SMA patients in subsequent clinical trials. Compounds which increased SMN2 activity in vitro but did not make it to the clinical stage include growth hormone, various histone deacetylase inhibitors, benzamide M3,4,4-hydroxamic acids, prolactin, as well as natural polyphenol compounds like resveratrol and curcumin. SMN stabilization. SMN stabilization aims at stabilizing the SMN delta 7 protein, the short-lived defective protein coded by the SMN2 gene, so that it is able to sustain neuronal cells. No compounds have been taken forward to the clinical stage. Aminoglycosides showed capability to increase SMN protein availability in 2 studies. Indoprofen offered some promise in vitro. Neuroprotective drugs aim at enabling the survival of motor neurons even with low levels of SMN protein. Alsoxium is a proprietary neuroprotective compound developed by the French company Trophos which showed stabilizing effect in a phase 2-3 clinical trial involving patients with SMA types 2 and 3. The drug is being developed by Hoffmann-La Roche since its acquisition of Trophos in early 2015. Riluzole is a compound that offered mild clinical benefit in amyotrophic lateral sclerosis and had some indications that it might be similarly helpful in SMA. A clinical trial of riluzole in SMA types 2 and 3 was conducted in 2008 to 2013, with no results published. Thyrotropin-releasing hormone showed some promise in an open-label uncontrolled clinical trial but did not prove effective in a subsequent, double-blind placebo-controlled trial. Compounds that had some neuroprotective effect in vitro research but never moved to in vivo studies include beta-lactam antibiotics and follistatin. Muscle restoration. This approach aims to counter the effect of SMA by helping to restore or regrow the lost muscle tissue. CK2127-107 is a compound developed by Cytokinetics. As of June 2016, it is in a phase 2 clinical trial in adolescent and adult patients with SMA types 2, 3, and 4. Stem cells. As of 2016, there has been no significant breakthrough in stem cell therapy in SMA. An experimental program to develop a stem cell-based therapeutic product for SMA was run, with financial support from the SMA community, by a U.S. company California Stem Cell starting from 2005. It was discontinued in 2010, unable to enter the clinical stage, and the company ceased to exist shortly after. In 2013-2014, a small number of SMA1 children in Italy received court-mandated stem cell injections following the stamina scam, but the treatment was reported having no effect. Whilst stem cells never form a part of any recognized therapy for SMA, a number of private companies, usually located in countries with lax regulatory oversight, take advantage of media hype and market stem cell injections as a cure for a vast range of disorders, including SMA. The medical consensus is that such procedures offer no clinical benefit whilst carrying significant risk to the patient. Therefore, patients are advised against them. Patient registries. Patients with SMA can avail of an opportunity of participating in clinical research by entering the details into SMA patient registries managed by TreatNMD. Notable people. Notable people who lived or live with spinal muscular atrophy include Alexa Dectis, American television actress, songwriter, public speaker, ambassador for the Muscular Dystrophy Association; Baroness Jane Campbell, Commissioner of the Disability Rights Commission and Commissioner of the Equality and Human Rights Commission; Hermann of Reichenau, an 11th-century Roman Catholic scholar, composer, music theorist, mathematician, and astronomer who likely had spinal muscular atrophy; Karen Wheeler, American artist; Kim Sarkozy, British actress and television presenter; Laura Hershey, American poet, journalist, popular speaker, and a disability rights activist; Marek Plura, Polish parliamentarian 2006 to 2014 and member of the European Parliament since 2014; Nicholas D'Agostino, an American motivational speaker, author, coach, radio host, non-profit founder, and entrepreneur; Pablo Echenique-Roba, Argentinian-born Spanish physicist, member of the European Parliament since 2014; Robinson Brink, a former Dutch football player. In popular culture, 39 Pounds of Love is a documentary film written and directed by Danny Menken and starring Amy Ankelevitz, an Israeli 3D animator who lived with spinal muscular atrophy. 97 Seconds, the third episode of the fourth season of House, features a man with spinal muscular atrophy who develops symptoms that could be related to his SMA or something else.